Okay, so how many we got in now?
20.
We've got about 60 coming. Shall we give it another few minutes then?
We could do.
I could have a look, see if I can get my camera to work.
Shall we start, Grant? I think it's 6 past 7 now. So we could probably start as people trickle in and then take it from there. Have we lost Grant? Grant, are you there? Sorry, guys, we're just having some technical issues. We should be able to start in a bit.
Has Grant now returned, sorry?
I think so. I'm waiting for him. Grant, are you there? Oh. Oh.
Okay, so can you all hear me?
Yes. Yep.
Unfortunately, I'm still blank, but no change there from usual, if anyone says that. So thank you all for coming. We have to be careful what we're going to talk about tonight, because obviously we're talking about a collective action, which is a BMA action. Now, the LMC isn't part of the BMA or affiliated to the BMA, but the legal advice gained by the BMA is that an LMC can pass on information, can help to organise things locally. But what we can't do is sort of change or influence what the actual collective action is from a national framework. Next slide, please. Okay, so where have we got to? So remember, this is the third year that we've had an imposed contract. So each year the GPC have looked at what the proposals are and said that actually it's actually we're creating more work for less or no funding, and therefore rejected it. So the BMA went out to a referendum initially, which 99.2% of GPs voted to reject the contract changes, and then went out to a non-statutory ballot, of which 98.3% of GPs of partners voted in support of the BMA's campaign, which includes the collective action we're talking about tonight. So the BMA, the list has got up and down and up and down, and we seem to have moved on, Charlotte, before I stop talking. Thank you. But there are now 10. We're not looking for everyone to do everything at one go. It's a marathon, not a sprint. You can decide to add your choice over days, weeks, months, or however long we go ahead. It's for practice to decide, but we're here to support you and to give you some practical help, hopefully, into how you can actually implement it. We hope that practices have read the full LMC guidance, and today we'll take you through that. So, Nanesh wants to come in. Do you want to block him? So do you want to move on to the next slide? I'm sure we had something on here. So where are we and why are we? So, I mean, we've talked about the background already, but just looking at locally, we know that because of the adverse effects of decreasing funding and increased workload, that number of GPs have gone down year on year. We know that the 5-year deal, which as an LMC, actually we sent motions to conference a year after it came in, saying that the way that PCNs were formed were likely to cause problems. And of course, the issue has been that during the 5-year deal, which was sort of predicated on having sort of a 2% per year inflation, that hasn't worked, and it hasn't been able to take into account increased changes. Those of you who actually read my newsletter would have seen actually the one that I sent out last week, where we looked at local funding, because our ICB are actually quite proud that they've actually put increased money into practice. It's gone up by 13% over the last few years, but actually take account the increase in population and the inflation over the last few years, which has been really high. That in itself has led to an effective decrease from 170 to 150 pounds per patient. So you've actually lost, in real terms, over the last 3 years, 20 pounds per patient. And that's why practices are struggling. And then we've got this other really bizarre thing, and that in effect, the government has taken out £2 billion from the contract, and they've put back 1.6 billion. But they've put that back in the ARS scheme, which means that you cannot use that proportion of the of your funding now for GPs, whereas in the past you would have been able to decide which staff you wanted, which were best for your practice. And that's led to the really odd situation, so that for last year and this year, where because of massive increase in number of trainees, there are actually going to be more GPs produced than leaving, but they can't get jobs. So that's the Kafka's position we are in. Can we move on? Next slide. I don't mind if people ask questions as we go along, or if they want to save them to the end. I'm going to turn on the chat function so I can see.
So we've had a question from Jeff about LPT and PRISM forms, so I thought we'd pick that up at the end of the thing.
Yeah, okay. Yeah. Or when we get to that question.
Yeah.
So the first one. Now this is the, to me, the biggest one, the most important one. This I think we need to do as a profession. And I think once it's done, none of you want to go back. It's absolutely balmy. You know, that we've got practice still trying to see 50, 60 patients a day per GP. You can't do it. When I moved to my current practice in 2016, it was usual to see 50 patients on a Monday. And, you know, it's just not doable. You cannot concentrate from that. So the UMO, which is the Union European de Médecine Ordinaire, is a pan-European organization. And they did some research looking into what do other systems do and what seems to be a safe level. And they came out with that a maximum safe level appears to be 25 contacts per day. There is quite a lot of evidence and research, not necessarily looking at general practice, but also looking at other specialties, which show that once you get above a certain number per day, and for some surgical specialties, you're talking about sort of 6 or 7 procedures a day, then your ability to concentrate, the likelihood of you making a mistake, the likelihood of you missing something goes up. Now, you know, when I was younger, and you had that sort of sadomasochistic, of course we can do it, you know, I'm young, I'm fit, I'm gonna do it, but actually that isn't in the best interest of our patients long term. So next slide. And just looking at the graph, this is one which I've shared widely, and I think is absolutely fantastic. And LMC somewhere else in the country also have enough time in their hands. They took the results from the patient survey for every single practice in England, and they also took the number of appointments that every single practice provides, and they mapped it. And as you can see, there is no correlation between patient satisfaction and the number of appointments that you provide. So staying on the treadmill, staying on the hamster wheel, as Katie always calls it, it doesn't get you anywhere. It doesn't actually improve quality of service, and it doesn't actually make patients more satisfied. You're just trying to achieve that nirvana that you'll never get to. It's a bit like motorways, you know, the solution in the past was, you know, if a motorway's full, you put another lane in. All what happens is that gets used. For those of us who remember the last Darts review, thinking about the one which is coming out very soon, you remember that one of the things that Darcy suggested was putting in walking centres, and every single area had to put a walking centre. And once central funding went, the areas closed them down. And the King's Fund did a review, and they actually found that there was no increase in meeting health needs by having them. Increased capacity, increased demand, but it actually had no effect. So actually, in the areas which had them and stopped them, they saw no increase in GP footfall or footfall through hospitals, through emergency departments when they closed down. So it just actually created more demand by doing that. So in my own practice, as I say, started, you know, around about 50. I gradually decreased it over the years, and we are now down to 25 a day. In fact, my partner's on here, we're down to 24 on average a day, or 24 set a day, which then allows us some leeway for some additional. What has been affecting our patients? We were getting loads and loads of complaints every week about access, and we don't. Our number of complaints about access to us has gone down. The number of satisfied friends and family test results has gone up. Because actually what patients want is that they want to be treated properly. They don't want to come into a room and be hustled out because, you know, as a GP, you're looking at the clock and wanting to get the next one in. So part of this is that we've also gone to 15-minute appointments. Okay, and I seem to have lost. Why have I lost my chat?
We have a question in there, Grant. So Dan's asking, we already operate when we are full policy. Patients will call 111 and then they're told to ring back the GP surgery. This leads to a standoff between 111 and the surgery. What are the chances of this changing?
Zero.
Yeah,
because
absolutely.
because the government won't do that. But of course, when you do divert to 111, a fair proportion of those patients won't come back. In my own practice, what we do is that we reserve slots in the afternoon for the duty doctor. So actually, they've got time to deal with the ones that we know that will bounce back. 111 also have the ability to book directly into appointments. And again, actually, what I've noticed recently is actually they seem to be booking less into them. So will we change the national policy on 111? No, but feel free to divert. And because NHSE's their own view is that you shouldn't be using 111, and of course the ICB has to follow what the NHSE tell them to think. They're not allowed to think for themselves. But actually, there's no contractual or regulatory requirement for you not to divert to 111. So just keep doing it. Just keep doing it. They will triage and they will divert 90% away.
This is the one bit in the collective action that seems to sort of scare a lot of people, and there's a lot of things around clinical responsibility and sort of where things sit. So it might be worth getting guys, you know, there've been lots of sort of questions on different sort of chat groups and stuff. It might be worth stopping here and just having a discussion and maybe hearing from everybody else. I know, Leslie, you've talked about how it actually works in reality and what you do, and it might be worth just sort of trying to open that out and having that discussion, because I know quite well that this is one that seems to really worry people.
Yeah, absolutely. It does seem to be definitely the one. I mean, for those of you who unfortunately caught me on the ITV news last week, he was actually in filming for almost an hour. He recorded stuff, and the question he went back over and over to was about this reduction to 25 appointments. And in fact, that was the only bit that they put out on the news, about a small snippet about that. So it definitely seems to be the one that is in most other people's minds. But what we need to do is to remind people what the evidence is, what this does about quality, what this does about staff morale, what this does about GPs being able to provide a proper service, and about patient satisfaction. Okay, shall we move on to the next slide?
There's a question in the chat. I think we have a large elderly population and a housebound patient list who are complex, who rely on GPs locally and have a reluctance to go anywhere else, and not sure how this could be managed.
You do it over a long period.
Yeah.
Again, sometimes it's changing expectations, and sometimes it's changing patients' reliance on general practice to just using general practice when they need general practice. Again, just reflecting on my own practice when I started. On a Monday, we used to get an average of 10 requests for home visits. And through the week, it would then die down. But over a week, you're talking about 30 to 40 requests for home visits. We started a relatively strict policy, but also insisted that everyone got a telephone call first. And then we looked at how else could the so-called problem be dealt with. Now, what we found is actually a lot of those that were requesting actually weren't medical problems. And by sticking to it, before the pandemic had started, we've got down to an average of 2 to 3 requests for home visits per week. So we've gone from, say, 30 to 3 per week, and that was just by saying, actually, let's look at see what actually needs a input from a GP. I'm not saying that that's going to be a solution everywhere, and every practice is different, but it is about trying to change expectations over a period, and remember, you don't have to do this overnight. I mean, so I had got our figures down. It's taken us from 8 years to get down from 50 a day to 25 a day, and we didn't do it in one go. And to be part of the action, you don't need to have done it in one go. To be part of the action, all you need to be saying is that we're doing too much. This is unsafe. This is not providing good quality service. We're going to start working towards a safer level. And if that's dropping from 60 a day to 50 a day, you're taking part of the action, you're doing your bit, and you are starting on that journey, hopefully, to what will be the long-term position for every practice. So the next one, stop engaging with e-referral advice and guidance pathways. Now, locally, there are no mandated by the ICB. We know that some specialties ask you to use it. And this is in your control. So if you don't want to use ANG, you say, no, I've done the referral. I referred to you for your opinion, and that's what I want. If you think ANG works for you, then feel free to use it. But it's just to be engaging with this collective action. All we're asking is that you're saying that if someone is trying to force you to use advice and guidance against what you feel is best for the patient and for your care, then just say no. Okay, any questions about that one? No, let's move on then. Charlotte, fallen asleep. Oh, here we go. Right, so notice on voluntary services currently undertaken that plug local commissioning gaps and stop reporting system. So as you probably know, when I took over as chair, I took this on as being very much that this was my mantra, and this was one thing that I wanted to deliver on. We have delivered on many areas. We've still got bits to go, but actually as an area, we are much closer to achieving this than elsewhere. We've also produced that guidance on what's core and not core. Now the guidance, we passed it to the ICB. They thought it was a bit too much of a hot potato. They passed it on to NHS England, who didn't want to comment one way or another, who passed it back to the ICB. So apart from some obvious places which we've changed because there are services that have been pointed out to us or whatever, this is the same as the original version. Do look at it, look through it. If you're providing services in there which are not funded for, consider giving notice and stopping it. Locally, the main areas of contention we've got in terms of health are the 48 checks of wheezy children and minor surgery. Now, we were in a meeting with the ICB this week, and I've made it clear to them that patience is starting to wear a little bit thin, and they have promised that this will be dealt with, and both of those will go live from the beginning of October. Now, they said they were going to send us an email with that in. I have got an email in my inbox, which hopefully it says it, but I haven't had time to open it and read it today. But it doesn't say it, friends. Shake your head. So I'll need to look at that. But this is what we're looking at about the voluntary service or being underfunded. Is that, I mean, for example, with the minor surgery at the moment, every time you do an injection, your practice is subsidising the NHS by £21.77, so 22 quid. Now that 22 quid is either coming out of the partner's money, their pocket, or it's coming out of money that you could be spending on other services, or it's reducing other core services. So each time you're doing that, and this is the same for many other services. as you'll probably remember, for phlebotomy, we actually had to negotiate 136% increase to get what they were paying to the level that it actually costs general practice to deliver. Now, so I have to keep reminding colleagues at the ICB, we are not asking for profit. We're not here saying we want a massive profit for general practice. I wish we were. The argument we're having at the moment is purely saying, actually, we don't want practices, we don't want partners to have to subsidise the NHS. So look through these. If the ICB does not deliver by the beginning of October, I think as an LMC, we will be coming back to you to remind you of these figures, suggesting that you look at what cost it is to your practice, therefore providing the services, and therefore whether you want to stop providing them and just refer everyone into secondary care for those procedures. When we were going through this with phlebotomy, for those of you who do read my newsletter, I know it's variable, I did put in there the figures for phlebotomy, how much it was actually costing us to subsidise. And we had one practice manager phone us and said that they had actually looked at this and they realised that the partners were paying £20,000. It wasn't a big practice, £20,000 out of their own pockets, for the pure pleasure of providing a phlebotomy service to their patients. Now that is not acceptable, and that does not lead to quality services for patients. It undermines your ability to provide services to your patients because it's taking funding away. And if you're taking out a partner's profits, that's why we know that many practices have closed because of financial reasons. And this is one of the reasons why you've got to be, I'm afraid, a bit more savvy in terms of the business side of running your practice. So again, this is one that we are, that the GPC England have identified to do now, but really we want practices to do long term, to always keep an eye on what you've been asked to do, how is that being paid for, how is that being funded. Now, some stuff you will choose to do, every practice choose to do some services for free. Some services you have to do for free because there's a legal requirement. But if it's not, question who's paying for this, and are they paying enough to actually at least cover my costs of doing it? And if it's an added plus type service, then what's the benefit the partners getting out of this? Now, what benefit are partners getting for taking on the additional risk and work for providing the service? Okay, next slide, please. So this is, again, we constantly get initiatives to try and prevent GPs from referring or to try and put you off from referring. And this action is to actually say, just don't do that. There's no requirement to use any particular referral template or pro forma. Can you go on to the next slide? So there's no contractual or professional requirement. In fact, the GMC just says that as long as you include relevant information, then that does it. The NHS Constitution entitles patients to be referred where clinically appropriate. It doesn't say, but only if you've done the serum rhubarb and have walked a tightrope and whatever. It just says just refer. So feel free to abandon the templates you don't like and just send a letter. Now, again, what this doesn't say is that you have to abandon all templates. So if there is a template that you like on PRISM because it's straightforward, continue to use it. If it's one which is asking you to do silly things or it's just a real bind to fill in, then stop doing it. We've had conversations, sensible conversations with the UHL, and they are expecting this, and they've told their teams to expect this. We have tried to have conversations with LPT and DHU LPT, I think we've now got a meeting in the diary, but DHU are not engaging with us. That doesn't say that you don't do it for DHU, which of course is mainly going to be I think the CYP mental health triage form, but you just go out and do it, and then if you have any problems, refer back to the LMC so we can pick it up with them, because it might take a bit to actually persuade them to actually talk to us about it sensibly.
So we've had a question or a comment by Jeff in the chat. He sent a referral to LPT for ADHD, not by PRISM, but just on a normal whatever letter, I assume. Response from LPT was okay not to use PRISM, but we are still required to send all information that would have been on the PRISM form and all documents as previously. Is that correct? And basically, I think you've explained that quite nicely. We're not mandated to do that. As long as you've got the right bits of information for you to make that referral, then that's fine. You don't have to fill in all their bits and pieces that they're asking for, and that's written quite nicely in this slide, I think.
Yeah, and I think it must be about 18 months ago. Everything seems to be merging on. We actually had a meeting with them about referrals, and in fact, we had an agreement in principle that they would do the chasing.
Yeah.
So that you would just do a referral, and then they would send the questionnaires out to the parents and the school to be completed. So you wouldn't have to do any of that part. So we actually had that agreement. I don't know why that didn't get implemented. It's probably because they suddenly realised how much work it was going to be and how much bother it was going to be for them.
Yeah.
But we actually, but on a sensible level, they did actually see that really that's what they should be doing in the first place. So as long as you put in the information which explains why you're referring that patient to that service, that's all you need to do. Okay.
There was a question. There was a question in the chat that we missed that Gailash asked, but it was to do with about the 25 context. I thought we can just pick it up while we're there. His question is: the safe limit of 25 appointments a day may lead to an increase in other queries from patients via EQRX or surgery, email, etc. What would you suggest? Not to engage with such communication. So I guess this is the online stuff, isn't it? Really.
It is. So under your contract, you have to dispose each of those queries, so you can decide how you do it. I mean, one of the ways that within my practice that we've done it is that we've tried to provide other pathways for patients to try and take them out of the mix. So we have a paper pathway for UTIs and for contraception updates and for HRT. And we're expanding on those. And we also send a lot of things directly through to our pharmacists. So anything to do with medication goes through to pharmacists. We are one of the highest users of Pharmacy First, and that involves training your healthcare navigators, your reception staff, to be able to do that triage. And if you do that, it won't mitigate everything, but it just takes it off. So if all those queries come in and they're looked at by your healthcare navigators and they can triage away the vast majority of them, then that will help you keep to the safe limit. As I said, I'm afraid there is no guaranteed solution, and you'll always have busy days, and you'll have days where your demand goes up and you can't keep to the 25. But we're talking about on average over the week, sort of trying to keep that sort of level.
And can you engage in such a way that when you've kind of reached what you think is your safe limit, then even these sort of online consultations, you could probably say if there's anything clinical that is, that the patient thinks is urgent, they're not allowed to communicate in that way then. So it's not sitting in a pile, I guess.
Well, turn it off, absolutely.
Yeah, absolutely.
So when you're full, turn it off.
Yeah.
Now you will realise that within the PCN DARES, it wants you to keep it on all the hours that you're open. Now we'll come to that in a minute, but basically GPCE is saying don't do it. So at the moment, don't engage with that. You can get your money if you say engaging it on the 30th of March.
March, yeah.
Okay, and then you'll get all your payment for the whole year. So you don't have to do anything now. Now, GPC is hoping that they can have some better conversations with NHS England and the government. And they're hoping that by doing this collective action, this will help them to be able to have that conversation with NHS England, to persuade NHS England to change that requirement. Okay, so next slide, please, Charlotte. Thank you. So hopefully every practice did this. Thank you for everyone that did do it over that weekend. I think this was absolutely appalling. We know from people who work within the IT part of the NHSE that this was going to happen. This was a thing. And I'm actually appalled at the very careful wording that NHSE used in their reply, which basically says not what it seems to say. And I did include that in one of my newsletters if you want to read what my thoughts on that were. But I actually, but it's actually appalling. But yes, they were going to do it. I think sometimes NHSE forget that people within the organisation are humans, and that they will share information. I mean, one example I can come up with is I don't even remember care.net, which came and went. But the government was saying, and NHS was saying that they weren't going to be selling the information. One of the people on the inside, because I was then chairing the GP IT committee nationally, the Joint GP IT committee, one of the people working within it actually shared with me, sent to me the price list that they were sending out to private companies, pharmaceutical companies, etc., to actually be able to buy the data, which I then shared with the press, and then, as we know, it then collapsed. So similarly, I still know people working in IT within the department at NHSC, and they talk to us. They talk to me, and they talk to people within GPC England, which how GPC England got to know about it in advance, because someone leaked it to them. Okay, so if you haven't done it, please turn it off, because the more people do that, the bigger it looks to the centre when they're looking at this data, and the stronger the message it is sending. Next slide, please. So this is one that I'll hands up that we probably need to be doing more locally. We've done some work looking at what you can't turn off. But what I haven't even done with my own practice is looked through how many are on there and which ones we can probably safely turn off. I'm aware from another LMC area where they have done more on this, is that practice have told them that they had between 40 and 80 of these on their GPIT systems, on which there's a handful that you actually have to have. And this is probably good housekeeping, as well as causing annoyance to the system, which is what we want to do. This is good IG housekeeping to say, of all these, which ones do we really need to have in place? Which ones are affecting us as a practice ability to get on work rather than helping other people? Because we're not there, I'm afraid, to help the system. We're there to treat our patients, and for this purpose, to protect our practices. So do you want to move on? No. No. Okay. So these are the ones that we've come up with, which are probably that you must do. And then there's one that the ICB has identified, which is provides information for CBS. But everything else, if you've got any others on your system, then turn them off. If you know where it's from, it's polite to give them notice that you're going to turn it off. But very few agreements actually require you to give particular notice. And it's when you don't identify it all, turn it off and wait and see. Sorry? Was that someone talking to me or just talking to themselves? Okay.
I think somebody was unmuted by mistake.
Okay.
Yeah.
Okay, so hopefully that's straightforward. I will, when I get a chance to look at it in my own practice, I will send out our experiences. Okay, can we have the next slide then? And this is to say, don't sign up to anything new. Okay, so basically, if you get anyone asking you to have a new data sharing agreement, whatever it's for, contact the LMC first, and we'll tell you whether it's whether there is a sort of a national regulatory requirement or our views on that particular extraction. Again, it will be up to you whether you do it, turn it on or not in the long run, but in the short term, just freeze anything new. We know that the government have got some WISO schemes coming up that we think are not probably appropriate. We don't know when they want to try and turn those on, but for the time being, as I can't remember what was his name. What was his name? Just Say No. Was it Dano or was it Dano? Just Say No. So next slide, please. This seems to be a bit. I don't know if you're seeing what I'm seeing. I've seen we've got an awful lot of POQs appeared for some reason. So switch off medicines optimization software. Again, turn it off. There has been some query about drug safety. Of course, you get that on System 1 anyway, about interactions. So that's already there. There is actually a lot of evidence that there is alert fatigue, particularly using these type of software, so that if you get multiple messages, you're actually less likely to act on them anyway. But if it's not there, you will choose the drug, the version that you feel is best for your patient, rather than one that the medicines team feel is the best this week, because of course it will change next week. And the one thing that I never ever see, and I've asked and challenged them before, is them actually calculating what is the cost to general practice to do it. They look at what savings they're making, but they don't say, but this has cost so much in GP time to achieve those savings. You never see that. Okay, next slide, please. So this is coming back to what we were talking about earlier, better digital telephony and simpler online requests. If you can just sort of go into the next slide, I think got more explanation there. So these are part of the imposed contract. You have to sign up to them by the end of March, we'd said before. The better digital telephony is nothing about better digital telephony. It's about NHSE having the data to micromanage you with and start putting targets in regards to telephony in the contract for subsequent years. And the simpler online request is nothing about making it simpler. It's just designed to overwhelm you by requiring you to stay open, to stay sucking in additional work, even though your practice has reached its safe limit and cannot safely deal with anything else. So, as I said before, GPCE is talking with NHSE and the new government, and they are hoping, particularly if everyone says no to this, if no one signs up to this, it will give such a strong message for GPCE to be able to go back to NHSE and renegotiate this within a year. So don't worry about your baseline. As long as you signed up before 31st March, so midnight on the 30th is fine, then you'll get the full money for the whole year. So don't panic, you'll get it. But by saying no at this stage, you will help GPCE in their negotiation stance with NHSE. Okay.
We had a hand up from Alison and then it's gone back down. I think maybe your question was answered.
If not, hand up. Okay, so we have next slide then.
Yep.
We've got plenty of time for questions at the end.
Oh, I think she got, yeah, okay.
So, well, that's why I keep flicking out.
Oh, yeah.
So number 10, this today doesn't affect us, but we would like practice to say that they are adopting this. So NHSE wants to expand PCNs, and they're throwing a lot of money at it. But those of us that have been around for a long time realise that there will be a lot of money for the pilot, a little bit of money for people come second, no money for anyone after that, and in future years there will be no money at all for it. The concern, particularly with what some of the pilots are looking at, is that this is basically asking general practice to take on secondary care work for minimal or no funding. It's also stripping out acute from chronic GP work. And of course, that undermines continuity of care, which NHSE keeps saying that they're great believers in. And of course, all the evidence is that it's a continuity of care which gives you better patient satisfaction and better health outcomes, and in fact, lower long-term costs. So that's the concern about these pilots. So GPCE is basically saying to all practice, just say no again. There are ICBs who are being encouraged to do local pilots. No, we know that. So that there are national pilots which are going ahead. But we also know that NHSE are talking to ICBs and trying to encourage them to do local pilots as well. When you have a sensible conversation with NHSE, as they quite sensibly say to you, they work in the system. If NHSE tells them to do it, actually they have no option but to do it. They can obfuscate a bit. I've been in that position before. I have worked for NHSE, well, the previous version of it back in the 1990s, and you get these things dictates down from the centre, and then you say, well, how can we implement this locally without upsetting and causing problems locally? But sometimes you don't get the option. So that's where we are. So that's all the 10 actions. We want to the next slide, because I can't remember what on it. Okay, so next big thing is engage with your PPGs, engage with your patients, tell them, talk to them. There's loads of campaign materials that you can display. There is we've embedded the links there that you can download, and there's a couple of examples that you've got on the bottom there. There are sort of like business cards you can hand out, which have got a 2D code on it to be scanned for patients that can go straight back into it. There's posters, there's car stickers, there's badges, there's lanyards. If you're really lucky, you can have a hat. And if you don't like that one, it also comes as a beanie. So if you prefer that one, you can wear these in surgery just to demonstrate that you are taking part in the collective action. So do look, and there's pens, and there's all the sort of stuff that you would expect from a national campaign. So on there you've got the you've got the hat and the badge, and the other one. These are the business type size cards that you can leave out for patients to pick up. Okay, so that's the end of. I think that's the end of our slides.
Yep, that is the end of
That's
our
the end of
slides.
slides. Okay,
yep.
So we are now open to discussion. I'm not going to call it questions and answers because I probably haven't got the answers to them all. We can take some away if they're more detailed, but I want more of a discussion. You know, what are you doing? How have you done it? Can you give tips and advice to colleagues?
So Leslie's put something in the chat. It'd be useful to have Leslie. Do you want to come in? Charlotte, do you want to stop sharing? And Leslie, we could get you to come and sort of tell us what you've done. You've written it in the chat, but that seems really positive as well around the 25 contacts. Sorry, I'm putting you in the spot, Leslie.
You're muted though.
You there still? Yes, there you are.
Are you still muted?
We can't hear you. Oh, can't hear you. Oh,
No, it actually does say that you're unmuted, but you're not. I think your IT and mine have got together. My camera's not working.
Seems like it.
Oh, you are now.
Yes.
Aha. Far away.
You've got me there.
Yep,
fantastic. I think we looked at the safe working limits, I think even before the action was recommended, purely just on recruitment, survival, and a genuine concern about just not being able to offer a quality service to the patients. We feel that we're just rushing through, and that moral injury that people are always feeling, that they know what sort of care they could provide, but you're actually looking at just churning through numbers as opposed to churning out good quality medicine. And I think we just, as a party, got a bit sick of it, to be honest. So we introduced the safe limit numbers. We do have obviously online access, but we know we actually limit that to an extent. We see the patients we can see, and the rest of them we explain to them, unfortunately, we're at a safe limit, they need to go to the urgent care centre. So far, satisfaction's gone up. We've been able to fully recruit to our posts, and staff morale's significantly better. I would agree with what Grant said. I don't think patient satisfaction is linked to access. It's linked with how they're treated when they come through the door. And you can't do that if you are constantly watching the clock.
Yeah.
I think we need to find the quality, not quantity.
And the survey, and the survey shown that, hasn't it? Like the survey shows that we have more access, but actually patient satisfaction has decreased overall everywhere, hasn't it? So yeah, that's really interesting. Nainish, do you want to come in? You had a question or your hands up?
Yeah, no, thanks for the presentation, Grant. I think it was great. I just wanted to get some further clarification on this 25 contacts per practitioner per day. That's very much about an individual, isn't it? But is there any sort of further guidance on, you know, per 1,000 patients, what would be, what the BMA or GPC think would be reasonable in terms of GP consultations, phlebotomy, you know, all the different gamut of staff that we have? Because of course, if it's 25 consultations per practitioner, if I was the only practitioner looking after our 14,000 patients, doing my 25 contacts, I'd be making, you know, £2 million a year and sitting very pretty on my 25 consultations per patient. Admittedly, all my patients would leave. It's just that this number is about a practitioner limit, but is there further guidance in talking about per 1,000? I'm sure there is. It's just I'm not aware of it, and if I'm not aware, I presume others may not be aware as well. Thank you.
So, not in the way that you're asking. So there's a lot of guidance on the BMI website about safe limits. So I suggest that you read it. You are right, but of course, if you were to do that, your contract says that you've got to meet the reasonable needs, and I'm sure that the ITB would come down on you and say you're no longer meeting reasonable needs if you were really running a minimised service. Now there is nationally. There was a suggested target of 74 appointments per 1,000 patients. Now, locally, for some reason, we went for 75.
Yeah.
But, you know, it's that sort of benchmark. Now, when we've looked before, and you'll probably know this more than me, Nainish, is that I don't think there's any practice that is consistently providing less than that anyway. And what's happened definitely over the pandemic is that we all ramped up the number of appointments and saw patient satisfaction fall. So it's that hasn't worked.
Grant, do you mind if I just come back on that before I just come in? I completely agree, but I still remain this word reasonable is very ambiguous, and it's used to mean different things by different people, depending upon what emphasis that they want to put on that argument.
Okay.
I think one of the things I'd sort of ask of GPC is to get rid of this ambiguity, which some of us admittedly find difficult, because I admit some of us use that word reasonableness in the way that we choose to interpret it. The ICB use it in their way too. And I think that makes it a little bit more difficult sometimes.
So yes, no, I agree. But it's better that it says that. It's better that there's ambiguity, because it actually allows you as a practice to decide how you want to provide your services. Now, we all work differently. As I say, within my practice, we now have a lot of doctor-like paper services for patients. Other practices have embraced, dare I say it, physicians, associates, and advanced nurse practitioners, and other staff to provide services. So it's up to you to provide the service that you feel is best for your patients. Now, if you've got your patient participation group on side, if your patients are giving good satisfaction rates, I think it's really easy for you to argue that you are meeting the reasonable needs. The arbiter is not the ICB. The ICB would have to say that you breached, and then they could issue you a breach notice, but they'd only be able to do that if they'd given you warning, and that you hadn't acted in a way to in response to that, in proper way to respond to that. And then even then, as a practice, you can appeal, and you can go to the NHS resolutions to get an independent ruling on it. And practices that have gone through that route and have appealed against breach notices, majority of them actually win on appeal. And as far as I'm aware, the last time I looked, and I'll say that this was in the days when John Canning was in charge of stats and regs nationally. He was saying at the time there was no precedent for what reasonable meant. So it's really difficult for the ICB then to say, but this is what reasonable means and not that. It's up to you. It's you. You've got the contract. It's for you to decide what's reasonable. And as long as your patients seem to be on board with that, then I think it's really hard for anyone else to challenge. So Leslie, you wanted to come back?
It was just to come back on Amy's comment there. As part of the work that we did as a partnership, we employed someone to actually look at our patient numbers with the contract in mind, with that number of 75 as the best number we could find. And we did get various sources to try and support that. And I would agree with Grant's interpretation of reasonable. We found that on some weeks we were offering double that, others triple that. And therefore, that's why we felt comfortable introducing the fairer, safer limit for both our salaries and our doctors, with the usual caveats in mind of, palliative care and speaking to district nurses and things. So it's rarely perfect. So that we could try and bring the number down. We're still nowhere near the 75, but it's a lot. We're not trying to meet that unreasonable demand. And we've really pushed the friends and family or Google reviews part, so that if we were ever challenged, we would be able to say, well, I hear what you're saying, but we perceive we're providing reasonable access as our part, and our patient satisfaction is now up. Our Google reviews for what they're worth are at the highest they've ever been. Complaints are at the lowest they've ever been, particularly around access. So we feel as a package, we feel we can fit within the ambiguity of that comment. That was the purpose of that.
Yeah, and that's great. And just coming back to the 74, 75, the 74, if you look at its history, is bizarre. It actually came from a report done by a national body is one of the big five actually accountancy who do health stuff as well, and they were actually commissioned to do it by a right-wing think tank, and the report actually has a forward by the then Conservative Secretary of State. So the pedigree of it is odd, but it then makes it difficult to be challenged by certain parts of the establishment that seem to want to challenge us about everything.
So there's a couple of questions back about, whether the 75 per thousand is weighted or just actual list size. And then a question, I think Nene sort of alluded to that around the consultations. Obviously, like a phlebotomy consultations, no, it's not a consultation. Phlebotomy is just an appointment. And so these were sort of clinical context that you're having, and I think it was taking into account that we have allied health professionals like physicians associates or ANPs or etc. So it was those that was considered, and I guess the 75 was per weighted, if I remember correctly.
It was raw list. It was raw list. Yeah.
But I think the thing with the ICB, the 75 was being used as a thing, but it wasn't supposed to. So if you were providing 65, but you were meeting the reasonable needs of your patient, that wasn't seen as being
so
wrong.
From what I remember, and Nanish was chair at the time and not me, but from what I remember, the agreement was with the ICB that if a practice was delivering more than that, the ICB wouldn't look at the practice. If the practice was delivering less than that, then the ICB, it was reasonable for them to go to the practice and say, can you justify why you're providing this level? So it wasn't a requirement, it was just a level below which the system would then say, can you just tell us why you think you're meeting the reasonable needs? Not that it's evidence that you're not meeting reasonable needs if you were below it.
Yeah, so the next question was, does the 25 context today apply to ANP, paramedics, physio? So these are clinical consultations. So yeah,
I was going to be naughty and say if you can ever get any of those stuff to do 25 at least a day, then you're doing better than I've ever done. This really is for partners, because actually other salaried staff on the whole over the years have negotiated reasonable workloads for themselves, and if they don't, they go. But for partners, we have just shoved it on ourselves over the years, and it's time to say no. Now that's also affected some the way that some practices use salaried and whatever. But actually, even in practices where salaried working, that if you look at what the partners were doing, it was well over what the salaried and locums were doing. On the whole, yes, you'll probably find an example out there where that's not true, but that's my experience. Any other questions? If we at the moment we are sending out the weekly tracker from the BMA. We were going to send one out ourselves, but and then they started doing it. So I didn't want to send you out 2 questionnaires to fill in. So far, we haven't had anything back from the BMA, but we hope. Well, what they're saying is that they will start breaking it down by area and feed back to us. But I suppose my question is anyone unhappy with filling a week in completing a weekly one for the BMA? And if we're not getting back timely and what we need in terms of data for what's going on at LR, would practices be happy for us to send out an additional one as well as the BMA one? Or would you rather say, let's just try and stick to the BMA and force the BMA to share? Any thoughts on that?
I guess a show of hands may help if everyone's happy. Asma says she's happy for us to send our one as well.
Okay.
Do 2. I think 2 probably will get a bit too much, isn't it? But we've got a show of kind of positive, so that should be fine.
It is, and I was hoping, and I did, as Farina Sharp will tell you, I have mentioned it many a times to the GPC that firstly that that I've raised it, and second, that they did actually say they would start sharing it, and third, that they haven't yet. And we've got a message from Kerry Spall
about PRISM. Yeah.
It's up to you. If you feel that you need to send that as being part of the evidence, if you feel that you've got enough evidence on what you've been told. I mean, this is a bizarre thing because they tell us to put all this information, but it's not information. I've asked the mum. They've told me this. Why don't you ask the mum? My observation is I think this kid's likely to have ADHD or autism. That's as far as I think I need to go. You want the information, then you get it. So sometimes you find that they come with a report from the school anyway, so send it on. If they haven't, it's up to you. Send without it. Say to the mum, it'll probably be helpful to get it from the school, but don't wait to get it before you send it.
And I think it comes back down to the referral letters. And obviously, you can't just send a letter saying, please see. Obviously, you're going to put enough information on there and explain why you've sent the referral. But you shouldn't be having to do all the extra bits and, like Grant says, the serum rhubarb and all the rest of it, because that didn't lead you to make your diagnosis or, question your diagnosis or whatever. So if you as a clinician have decided that you think this patient has ADHD or needs to be assessed for ADHD, then you do that. You don't need the school report for you to make that decision. That's for them to make the decision, isn't it? So yeah.
I mean, in the 10 minutes I've had with a kid, or 15 minutes these days, is that really enough time to tell whether a kid's got autism or ADHD? You might tell that behaviour is a bit odd, a bit strange, but actually whether the underlying problem is neurodivergency, who knows? Okay. Any other questions? We thought we'd be, from everything we'd be getting through the MC inbox, we thought we'd get loads of questions, loads of queries. Now's a chance to, or discuss. Anyone else want to tell us something that they've done already that they're willing to share? Has anyone looked at the data sharing within their practice and started to turn them off? Has anyone actually started that bit of work? Yeah, to me, that's gone to the bottom of the this is going to take too long to do at the moment, but I will get around to it far. I was just looking to see whether there's any of my partners on that I could give it to while I'm here tonight. Okay. Anyone? Come on. Someone else got any observations? Are we all happy? Do you want to give a thumbs up? Give a thumbs up if you are participating in the collective action. Let's see how many thumbs we get in the reactions. We're getting quite a few thumbs, but I'm going to say there's lots where we've got no thumbs. Do you want to react?
I guess
I've got no idea what that symbol means. Is that thumbs up with a pinky as well? All right. That looks like more like it's a down with the kids type expression. Yeah, that's better.
It's a fist bump, I think, isn't it?
Would anyone like to have their practice decided not to be involved and wants to sort of just say why? We're not here to jump on you or to say that's not a good decision, but I'd like to be able to understand why, and if that's just because that's always going to be a position, or is it because there's something else that we can help you with?
Grant, while we're waiting for that, I missed a question from Tracy, actually. I've just realized. So limiting context will affect the drive from the PCN to capture activity data on the ledgers. We have been spending time trying to capture all context. This conflicts. Very difficult to know how to land on it. And I think it was that bit around, I mean, I'll let you come in anyway.
Can you find me the actual question? Because I didn't get what the question was from what you've just rambled.
Sorry. So limiting context will affect the drive from the PCN to capture our activity data. So obviously PCNs are capturing the data as part of their bit around the enhanced access and their CAPE plans, etc., etc. So
okay,
please,
right, yeah. So yeah, absolutely. So this is about capturing workload. That doesn't mean that you stop capturing other stuff. So it doesn't mean that you try. So we have definitely for duty stars, we have a virtual list which captures all the med 3s and other such queries. So it captures that workload, even though they're not really full patient contacts. So absolutely do capture as much as you can. Do have simple ways for your doctors to put on when they've had to do additional work, because the more that captured, the more we feed back to the centre how busy we are overall anyway.
I hope that answers your question, Tracy.
But we're getting off the hamster wheel. We're getting off the, going round and round in circles, just forever trying to run faster, because you'll never ever achieve what the demand is by doing that. And what we know is from experience is all that does is that it just gradually pushes down patient satisfaction. And there's also risks that you're doing something about safety as well, affecting safety as well. Okay, any other questions? Have we come to an end? Okay, well, thank you, Leslie. Thank you for your comments. Absolutely. So GPs need to be doing what GPs need to do. We're not, although we like to look after our patients, but we're not social workers. We're not social prescribers. We should be retaining our skills for where our skills are needed. That doesn't mean that we don't care for people. It doesn't mean that we signpost. We don't signpost people. It doesn't mean that we make sure that people are looked after. But it doesn't mean that you have to do it. That's my view. Happy to be corrected. Yeah, yes, you can have the slides. I think they were actually sent out with the invite, but we can send them out again.
No, we haven't. We'll send them out. We haven't sent them with the invite. We'll send them out after this.
Oh, okay, that's fine. Okay, any last questions then? Otherwise, I'll declare the meeting closed and I'll go and get a pint.
Ricky,
come on. Oh God, there's always one.
Oh, it can't be a meeting without me trolling you, Grant. Sorry. So yeah, great talk. Thank you for this.
Turn your.
Can you hear me? Okay.
Yeah.
We can't
Turn
see
your
you,
camera on.
Turn your camera on.
Oh. Yeah. So the question I have is that.
No, turn it off.
I knew you were going to do that. So the question I have is more about why there was only 60% turnout, and does BMA understand, or does the GPC understand why that was the case and how that will affect people participating in this action? And
yeah, okay, so 6% turnout, we know that there's some technical difficulties for some people. We don't know why people didn't vote. But 6% turnout on such a poll, if you look at other trade unions, it's actually really high. I mean, you have to achieve the 50% in the poll, and as you know, there's been some of the health unions haven't been able to achieve the 50%, and they haven't been able to take any action. So 60%, I wouldn't demean it, because actually it's good. And the incredible 2% that said yes to the collective action is fantastic. If you look at the survey that Pulse did, again, this was really early on, only 7% of practices says that they weren't going to get involved. So this was self-selected, but so that means 93% were either already doing it. I think there was 20% were planning to do it in the future. 20% were ready to go live now, and the rest had already implemented some action. And that survey was done a couple of weeks ago now, right back at the beginning of this action. So what seems to be on the ground is that we are is that the vast majority of practices want to be involved. And as I say, to be involved, to say I am involved now, all you have to be doing is one of the actions or working towards one of the actions. And then you can say, as a practice, we are involved in this. Now, we would like all practices to do more than one, but you don't have to do the lot. And I hope that all practices will have a real good look at number one. And even if they don't feel that they can implement that now, start working towards it. Okay, your life will be so much nicer. Your patient's life will be so much nicer. So do really look at that.
And interestingly, we've had a comment in the chat from Sumit, and he didn't get an email to vote despite chasing and requesting a few times. So I wonder, Ricky, whether that 60%, like Grant said, there was a few that really didn't because of the technical issues that had happened. So yeah, anyway, there we go.
Yeah, great.
Asma,
I mean, the 60% was actually 60% of people who had been sent a vote.
Absolutely, yeah.
So that wasn't all partners, because the only people that could be it could be sent to were BMA members.
Absolutely, yeah.
So we know that not all GPs are BMA members.
Asma, you have your hand up. Do you want to come in?
Hi. Yeah. On one side, we are trying to have a collective action, and we are also trying to work safely. I'm just wondering, the government or ICB or NHS England is asking us to do same-day access. That is from 6:30 to 8 till 8:30 or 9 o'clock, working Saturday 9 to 5 and Sunday probably 9 to 1 o'clock. Where does that fit into safe working?
It doesn't. And what I'd say to you is that as a GP in your practice, say no to that. Don't be attracted by the money. Think, do I really have capacity to take on something else? Now, this is additional contracts. This isn't within your core contract. It's not within the PCN DES. It's something else on top. So, if you want to do it, think about how you're going to staff it. But please don't staff it with GPs who are already working maximum safe levels. Within my practice for the enhanced hours, if you do those enhanced hours as a GP, you get them back. We take them off. You have some time out during the week in recompense for you doing them. There's no additionality to it. These are not additional appointments. This is just providing appointments at a different time. So look after your GPs, look after yourselves. Don't sign up to something unless you've got a cupboard full of additional staff that are not currently working to staff it with. I don't know why locally that they're looking at the way that they did. If I was in their position, I think I would start from a different point. But that's, it's the ICB, it's their decision to try and commission it the way that they are. And it's going to be whether PCNs want to take the money. There was I don't know if you remember Lawrence Buckman, who was chair of GMSC many years ago, but he said, the quickest way to kill a GP is to roll a 50p piece in front of a bus. Now, as a profession, sometimes we keep looking at what the revenue is rather than what the bottom line is. So are we going to make a big profit out of this? But also, are we going to have to sacrifice something else by doing it? Like, are we going to have a very tired workforce?
I accept tired workforce, but considering there has been less locums available, so there will be many GPs who would like to work
As I say, if you can, if you can find the staff to those separate GPs to run the service, and also remember that you're also going to need people with responsibility for running it, for supervising, for dealing with all the clinical issues coming out from it, and complaints and all that stuff. If you have got leaders within your PCN who've got the time to do that, and if you've got the clinical staff who can provide the service, then look at it. From my point of view, I don't actually interact with our PCN. I'm not our lead. I do to a certain extent, but I'm not our lead for the PCN. But I mean, my view is I wouldn't want to be involved in this at all. Being just an ordinary GP in a practice, I don't see any benefits to me. Now, for the PCN, if they could organise it, but I think it's odd. In the past when we've looked at, years ago, you may or may not know, I worked in public health, and we always looked at populations between 100 and 250,000 as being the minimum size that you need to be able to commission a reasonable service. And what they're trying to do is to commission it from PCNs who are much smaller than that. And I just don't think that makes sense. But that's my personal view. Lots of people will disagree with me, and I'm sure that some PCNs will be able to make it work.
Ricky's put
Thank you.
Ricky's put a comment in the chat. How do we know collective action is working and putting pressure on the system? And can we share ways that are keeping patients, or share ways that we are keeping patients on our side?
Okay, well, say so. You use the stuff for your patients, engage with the PPG to try and keep patients aside. We will, as an LMC, we will continue to try and put information out there to patients. We've done a whole series of press releases, as you probably realise, over the last couple of years, to tell the public about where general practice is going, and that we were getting close to this. How do we know it's working? Well, one of the reasons why I know it's working is that Wes Streeting announced the ARS scheme for GPs the day that the result was going to be released. I don't think he would have even done that at that stage if this wasn't coming. So we are seeing this, and the ICBs are really worried about it. There's a lot of pressure from NHSC on ICBs to understand what's going on, to try and sort of minimise it. You'll get lots of stuff from the ICB and NHS England. The NHS England sent out some supporting guidance, which was neither supportive nor terribly good guidance. So if you want to read it, that's fine. It might help you sleep. If you want to recycle it as something useful like a firelighter, that's probably even better. But the stuff that is being sent out by the ICB and being sent out by NHS England is to try and dissuade you from being involved, because they are really concerned that this is going to put pressure on the system. Okay, but we want to put pressure on the system because that's the only way they're going to change. Now, as I think I put in my last newsletter, to me, I think the government are listening. But to me, unless NHS England changes, unless we can get NHS England to change their ethos, then this will fail, because for some reason they hate general practitioners. And I talk to people who work with NHS England, and they'll tell you this. Know that there is this strong ethos within NHS England that they don't like GPs. They don't like our independence. They don't like the fact that we do have nebulous terms like reasonable in our contract, rather than being tied down to a definite level. That they just don't like it. So this has got to put a lot of pressure on the system, so much pressure that we see change in the ethos and change in our relationship with the centre, and also change in the way that general practice works. By the end of this, a lot of stuff that you're doing will be embedded, and you will never go back. Okay, you won't be going back to trying to see 50 to 60 patients a day. you won't do it. Charlotte says the LMC has an available to walk initiative. I didn't realise we were doing cooking classes as well.
And I think in answer to Ricky's question as well, this is a marathon, not a sprint, isn't it?
Absolutely.
So we're going to
So
see,
yeah,
so
coming back to Charlotte's comment, that we've got this available to work initiative. So what we've done is that this is like a reverse marriage guidance type thing, whereas if someone's looking for work, they can provide us with a CV and what they want to do, look on it, and you might be able to find someone if you are, say, looking for someone to do your extended rather than enhanced hours, and see if there's people available on there. So do use that initiative. If you are looking for additional work, then do use it. If you're advertising posts, is a bit of a freebie. The LMC provides free adverts. One thing I'd love to do is to stop people advertising on the list server, which just annoys me. I think most other people. Why do I get adverts asking me if I want to work as a practice nurse or a healthcare assistant every day? But if you want to advertise, put it on the LMC website. It's for free. The more people that advertise on there, the more it will get used, and the better it will be. Okay, any other questions?
Yeah, we've got Dr. Hirani with her hand up. Do you want to come in?
Hi there. Sorry to delay your pint. I may have just missed something at the beginning because I couldn't join. With regards to the 15-minute appointments, do you, how strongly do you advertise that to the patient?
We didn't tell them. We still haven't told them. No. As far as we're aware, they don't know. All they know is that they're not being rushed out the room.
Okay, because I suppose that's the difficulty, because I personally wouldn't want to tell them, because one of the reasons for moving to 15 minutes would be that you can get your prison forms done, which there are so many more of since COVID because of everybody coming with all their ailments that requiring referral and their expedite forms. So your recommendation would be not. So I suppose my concern is if access is worse with reducing the number of appointments available for patients to be seen face to face, then do we stop the staff from saying, well, you'll be getting 15 minutes?
No, yeah, absolutely. Yeah, no. Yeah. Well, our staff don't advertise it. We don't advertise it. We didn't tell anyone that we were going to do it. We've got no intention of doing so. But for the patient, patients are just seeing that they're seeing what we're seeing now is that our friends and family tests slips that we were getting a year ago. Most of them I couldn't read out in public because they were quite abusive, reflecting what a lot of our population are like where we work. But now 99% of them are positive, and we're providing less appointments. Go figure, really. Would ask NHS England to have a look at that, but they don't. And again, it's coming back to the graphs I put out right at the beginning. You know, that there is no correlation between the number of appointments that you provide and patient satisfaction. Now, you do need to think about other pathways when you're doing this, and you do need to do it over time, because otherwise I think you probably would have a right from your patients. Well, I mean, we changed overnight our system of how you get appointments, and we got a lot of flack. And reflection, we probably should have gone for sort of more of a soft introduction first.
How long have you been doing it for, the 15 minutes?
15 minutes we've been doing for about 6 months now.
Okay. So
we started reduced number from 8 years ago. I started reduced number we saw a day.
Okay. All right. Is there a recording of this that will be sent to us after?
Yeah, we will do that. We'll be sharing that. Yeah.
Okay.
And I'm just going to say, don't do prison forms and don't do expedite forms. It's not your job.
No, we know. No, totally. Ready for that one. Yeah.
Fair enough. We have a question from Michelle Grant. What support do you put in place for your reception and admin staff who will initially feel the brunt of patients' frustrations at reduced appointments and increased admin workloads from bounce backs, etc., from hospitals?
Okay, so in terms of the admin staff and the reduced, because we did it slowly, we did it incrementally over quite a long period. There wasn't, we didn't go for a big bang, and so there was never a day that we'd say, actually, this day we're suddenly going from such. I think the only one that really had a big effect is that when I joined, they used to have a walk-in service, so any patient could roll up to the practice. And they will be seen on the day. And so that meant, on one of my highlights of one of the first Mondays I worked at practice is that I had 50 patients. And I said to the large remaining partner from the previous partners, we ain't going to do this from next month. But apart from that, everything has been done incrementally, and we've looked at other pathways to try and offload other people from it. The CPCS, when it first came in, we embraced that from day one. As a practice, we were as Ricky's probably coming in to tell us, we were the highest using practice in the country at one point. So we've embraced all of those systems to help debulk the patients that are needing GP appointments. So do it incrementally, and you won't get that huge. In terms of the bounce backs now, you use the wordings that we have given you, use the guidance that the GPC and the standard letters that they provided, and UHL, as I say, we've actually already tackled, so they've already told their staff, so you shouldn't get that much bounce back. I think it's going to be more LPT and DHU for the time being until we've managed to persuade them otherwise.
Ricky, did you want to come in?
Yeah, I was just going to say, in terms of how do you prepare your staff and reception and even patients potentially, if you're going to do something, and tell them or change the system. One thing we learned, Grant will know, is that communication is key to everything that you do in terms of that, and informing your staff, explaining what you're going to do, having a clear plan, maybe having some sort of trial period, and the launch. As Grant said, we did it quite slowly, and even as slowly as we did it, there was still friction, and you got to expect there will be bumps in the road, but then staff get used to it, patients get used to it, and then they find a rhythm. And also, I've got to say, I've never been happier in terms of 15 minutes speaking to my patients and actually having time to say, listen to them properly. And been good as a clinician. It's definitely my consultation. Patients all felt that as well. So really positive change. Would endorse. And if anyone wants to get in touch with me or share stories.
Yeah, you're breaking up, I'm afraid, Ricky.
Yeah.
The bit where we did get a lot of negative feedback was because we went to online booking requests for appointments and turned off ability to do it by telephone or direct to trade. We did that overnight, and that was a mistake. We should have done that really as a soft, gradually got people changed over rather than doing it as a big bang, which is, you learn from your experiences. But even now we don't get complaints about that. In fact, I get more positive feedback from patients about the new system than negative now, a lot more. People don't like change, so yeah. But if you spring it on them very slowly, so they don't realise, boiling frog and all that. Okay, can we declare the meeting closed now?
Think so. I think there's no more questions.
If anyone's got any other questions, feel free to send it into the LMC office, and we will answer as many as we can. There's obviously going to be a lot of questions which aren't answered yet. We will send stuff out. There is something which has come out today. You'll have had a notice about turning on through CQRS data regarding your telephony service. The GPC has sent out a message today to say ignore it for the time being. The government can send out these notices, but only if it actually complies with the legislation. And at the moment, GPC is querying whether it does actually comply with appropriate legislation. So it hasn't got to be turned on to next month anyway. But so we're saying at the moment, don't act on it. If you see something appear on CQRS, do not act on it yet. Wait until you get more information through from the GPC. Okay, I think we've covered everything, so I will declare the meeting closed. Say, do let us know if